Hi guys, so today we're gonna talk about stroke. This is gonna be really basic. I'm just gonna stick to the ones that I think would be the most useful for our exams. But I'm probably gonna do another stroke video that's gonna be a little bit more detailed than this. With that being said, let's get started. Okay guys, so let's start a discussion with TIA. So TIA is transient ischemic attack. So this is a transient episode of neurologic dysfunction caused by focal brain, spinal cord, or retinal ischemia without acute infarct. So a TIA looks exactly like a stroke, but the symptoms resolve and there is actually no brain infarction. Okay, so that's the key here. There's ischemia, but no infarction. And that's because the clot inside the vessel, inside the arteries in the brain, they actually dissolve fast enough to the point where it doesn't cause any infarction of the brain tissue. Okay, so the previous definition of TIA actually is more of a time-based definition. So basically the definition before was like stroke symptoms lasting less than 24 hours, which actually now is very inaccurate because they did a study looking at patients with suspected TIA, and some of the patients they found actually when they did MRI scans that some of their brains had actual brain infarction. So they didn't have a TIA, they had a full-blown stroke. So now what we're doing is we're moving away from this time-based definition. So now the official definition of a TIA is basically a focal brain ischemia that doesn't result in infarction of or the death of the brain tissue. Okay, so in terms of physical exam, some of the findings that we would find are the ones I've included here. So we can find amaurosis fugax. So amaurosis fugax, it's basically the painless temporary loss of vision, either in one eye or both eyes. Okay, so this is painless and temporary loss of vision. And this happens because the internal carotids are blocked and they are kind of hypoperfusing the ocular arterial circulation. So the eyes are not perfused. So that's why we get this temporary loss in vision. Okay. It may feel like the curtains, the patient would describe this as like patients are like, curtains are like coming down and their vision is darkening. Okay. We see this in stroke as well. So also when you auscultate their carotids, you might hear carotid bruit, and this bruit is because of turbulent flow of the blood through that stenotic, that narrowed vessel because of an atherosclerotic plaque. So these are some of the symptoms that you might find in a patient with TIA. Okay, so now let's talk about the diagnosis of a TIA. So the first thing that we need to do is we need to do a neuroimaging study. So that's either a CT or an MRI. So from working in the hospital, I've noticed that they do a CT head first before an MRI because CT is just, you know, a lot less expensive and it's a lot quicker than an MRI. But an MRI is far superior than a CT and it's a lot more sensitive than CT, but it takes a longer time and it's more expensive. It's not available everywhere, to be honest. So after a neuroimaging study, which usually would be CT head, we will do a neurovascular imaging. So we will do like an MRA, like a magnetic resonance angiography, or a CTA, so CT angiography. And this is, or even like a carotid ultrasound, this is just to rule out any obstructive lesions in the artery of the affected like territory. So if for instance we have like atherosclerotic plaque in the carotids, then potentially that can be a cause of the stroke. So we're looking for potential causes or like sources of the clots if we're gonna evaluate for like an ischemic stroke, if we suspect an ischemic stroke. So that's why we would do a neurovascular imaging, looking for clots and looking for potential sources of these clots. Also carotid ultrasound. Another one that we can do is an ECG, and this is to rule out, again, other potential causes of an embolus. So if we do like an ECG, we can potentially see AFib, and we know from internal medicine 1 that atrial fibrillation, one of the most common complications, is a stroke because of the blood stasis. The blood pools in the like atrium, and then it can travel up to the brain, like the clot can travel up to the brain. So if someone has AFib, it can potentially lead to strokes. We can also do an echo, so an echocardiogram, and this is to rule out other, like, just embolic sources of clots. So for example, if someone has like vegetations in the valve leaflets because of something like infective endocarditis that can travel again up to the brain and cause an ischemic stroke in the brain, then we need to identify these potential sources of stroke. The last thing we can do is just like lab tests. So for instance, just a finger stick glucose to rule out metabolic causes like hypoglycemia, because hypoglycemia can actually mimic some of the symptoms of stroke or TIA. So we need to rule out hypoglycemia, and bloods as well, just to rule out any other like hematologic causes or infective causes of the symptoms that we're witnessing from this specific patient. Okay, so that's everything for diagnosis. In terms of treatment, so the first thing that we need to do is like give them antiplatelets. So if it's a cardiogenic cause, like a clot somewhere else in the arteries, or like AFib or something like that, we need to manage that. Okay, so if it's a cardioembolic source, like I said, like a thrombus formation that can potentially embolize somewhere, we need to put them on anticoagulation. So like warfarin, your DOACs, like your apixaban, rivaroxaban. Antiplatelets, again, like aspirin and clopidogrel. I will talk about how we determine like what to put them on in the later slide. Okay, I'm just giving you all the potential management plan. So if okay, another thing we can do is like revascularization. So for instance, we did like a carotid ultrasound and there is a plaque formation there. We can do a carotid endarterectomy. So the thing with, okay, let me just say this, for revascularization, so like carotid endarterectomy or like carotid artery stenting, these are reserved for patients with a significant blockage, so with a significant occlusion of about 50 to 99%. And for carotid endarterectomy specifically, these are reserved for patients with life expectancy of more than 5 years. So with the carotid endarterectomy, what we do is we cut the carotid artery, we take the plaque out, we extract the plaque, and we suture the artery again, okay? And like I said, this is reserved for significant occlusions, 50 to 99%, and for patients with life expectancy of more than 5 years. Carotid artery stenting is just placing a stent in the carotid artery that can hold it open, so that to reopen up the occluded artery. Okay, and last but not the least, we need some sort of intensive risk factor management. So we need to manage other risk factors that the patient may have. So if they have hyperlipidemia, which can then potentially lead to the formation of thrombus in like the vessels, then we need to put them on like anti-hyperlipidemia drugs, okay, so like statins and things. If they're hypertensive, which is another risk factor for stroke, then we need to put them on antihypertensive medications like ACE inhibitors, beta blockers, and things like that. If they are a smoker, because that's also a risk, advise smoking cessation. If they have diabetes, for example, we need to manage that, because again, that's another risk, so we can put them on metformin or things like that. So we need to manage any other modifiable risk factors so that this patient doesn't get another episode of TIA. TIA is a warning sign. Not everyone gets a warning sign. Some people just get a full-blown stroke. So if they've already had a TIA prior, then we need to be be more aware and control the potential risk factors that they may have that can lead to a full-blown stroke. So that's the goal of the management of a TIA. Okay, so we have this ABCD squared score for TIA. So this is just to assess the risk of stroke following a TIA and to kind of help us determine what kind of treatment or management plan is needed for this patient. Do we need to put them on monotherapy, just aspirin, or a dual therapy, so aspirin plus clopidogrel, things like that. So don't memorize the criteria. I just want you to be aware that this scoring system for TIA to assess the risk of stroke exists. Okay, so A stands for age. So if our patient is over 60 years of age, they score a point. If their blood pressure systolic is greater than or equal to 140, or diastolic greater than or equal to 90, they score another point. Clinical features, if they have like unilateral weakness, they score 2 points. If they have just isolated speech disturbance, they score just 1 point. The duration of the TIA symptoms, if the symptoms last more than or equal to 1 hour, so 60 minutes, they score 2 points. If it's between 10 to 52 minutes, they score 1 point. And if it's less than 10 minutes, they score 0 points. If diabetes is present, they score a point. Okay, so you'll see why it's A, B, C, D squared, because it's A, B, C, D, and D. Age, blood pressure, clinical features, duration, and diabetes mellitus. So once you've calculated all of that, if the score is 0 to 3, it means that they have a low 2-day risk of having a full-blown stroke. They have like about 1% chance of having a stroke in 2 days, okay, in the next 2 days. Score of 4 to 5 means moderate risk, and score of 6 to 7 means high stroke risk, like about 8%. So this just is a guide to help us plan the management for the specific patient. Okay, so moving on to the different types of strokes. So we know that there's 2 main subgroups. So we have ischemic strokes and hemorrhagic strokes. So ischemic strokes, they are a lot more common than hemorrhagic strokes. So hemorrhagic strokes are less common. Ischemic strokes are a lot more common. And within ischemic strokes, there's 2 subgroups. So it can be thrombotic or embolic. And I'll talk about this in a bit. So ischemic stroke, I want you to think about clots, about occlusion, ischemic, okay? So ischemic stroke is the sudden loss of blood circulation to an area of the brain, leading to death of tissue and loss of neurologic function. And again, this is because of a clot compromising the vessel, leading to the hyperperfusion of that specific area of the brain, leading to the death of the tissue. So, as I said, there's 2 different types, thrombotic and embolic. Thrombotic is a lot more common than embolic ischemic stroke. So thrombotic means that you know where that area of damage is, that's where the plaque buildup, that's where the clot originated. Whereas embolic means that the clot is from a distant site elsewhere that's just lodged in that artery in the brain. So the most common cause of an embolic stroke is actually a cardiogenic source, is actually atrial fibrillation. So in atrial fibrillation, the atria, sorry, they're not pumping in a synchronized manner, they're just quivering, yeah, they're fibrillating. So they're not effectively pumping the blood to the ventricles, meaning that the blood is becoming static, it's staying inside the atria. So with blood stasis, you know, virtual striae, we're more likely to develop clots, and that clot can travel up to the brain and cause an embolic ischemic stroke in whatever artery it blocks. So the clinical manifestation depends on the artery that's occluded, okay? So I'm gonna give you one example. If that artery lodged, if that clot lodged in the middle cerebral artery, for example, MCA, then we can have some like aphasia and involvement of the face and the arms, okay? So that's just one example, but we'll go over the different types of ischemic stroke in a bit. But for ischemic stroke, I just want you to remember that it's because of a clot, it's because of an occlusion in the artery in the brain, either because of atherosclerotic plaque formation inside that specific artery, or from a distant site elsewhere, which means it's embolic. Okay. Okay, so let's talk about anterior cerebral artery stroke. So this is a type of ischemic stroke where the clot is in the anterior cerebral artery. So if there's a clot in the anterior cerebral artery, then it's going to affect the contralateral side, so the contralateral foot and leg. So for instance, if it's the left anterior cerebral artery, we're gonna see right side involvement of the foot and leg. If there's a right anterior cerebral artery occlusion, then we're gonna see left side foot and leg involvement, basically the contralateral side. So this involvement can be like paralysis of the leg and foot. So the way I remember this is anterior. So here, anterior cerebral artery, ant. It starts with ant. So I think about an ant. And when you see an ant, what you do is you lift your leg and you step on it with your foot. You step. I mean, I don't advise on killing any animals. I don't do this myself, but this is just to remember. If you see an ant, you lift your leg and you step on it with your foot. So anterior cerebral artery stroke has leg and foot involvement, but just remember of the contralateral side, and this can be paralysis of the leg and the foot. Okay. Okay, so the next one is middle cerebral artery stroke. So if there is an occlusion in the middle cerebral artery, again, it's going to affect the contralateral side, but of the arm and the face. Okay, so if there's an occlusion in the left middle cerebral artery, it's going to cause paralysis of the right arm and face, and vice versa. So if there is an occlusion in the right middle cerebral artery, it's going to affect the left arm and face. Also, we're going to have some aphasia, which is, if you remember, aphasia is like the difficulty in producing and or understanding speech. Okay, so there's two things I need you to remember here. So middle cerebral artery stroke, ischemic stroke, is actually the most common ischemic stroke. So MCA is the most common artery to be affected in an ischemic stroke. So it's easy to remember because MCA, middle cerebral artery, stands for most common artery. MCA, most common artery. So most common artery to be involved in an ischemic stroke. The other thing that I need you to remember is if you change mid, so middle cerebral artery, if you change mid to mad, like this guy here, he looks really mad. So what is he doing? He's lifting his arms up in the air. His face is turning red because he's mad and he's yelling, ah. So this would help you remember the clinical presentation for a middle cerebral artery stroke. So he's lifting his arms up in the air, his face is turning red, and he's screaming. So lifting arms up and face, that are the specific areas or regions that are involved in a middle cerebral artery stroke, and the yelling would point you back towards the aphasia. So middle cerebral artery stroke is the most common ischemic stroke, and the presentation would be arm and face involvement, like paralysis plus aphasia, and the arm and face would be the contralateral side would be affected. Okay, so this is how you remember it. Okay, so moving on to PCA stroke, so posterior cerebral artery stroke. The presentation would be, there's two very specific things. So one is homonymous hemianopia. So homonymous hemianopia is a visual field defect involving the contralateral side. So it looks like this. So half of the patient's visual field is not going to be processed. So they're missing like half of the visual field in both eyes. And this is just extra information. This spares the macula because the macula is actually perfused from a collateral flow from the MCA. So it's not the PCA perfusing the macula. But anyway, homonymous hemianopia we are going to see in a posterior cerebral artery stroke. So this is this visual field defect affecting half of the visual field, which is not being processed. So the way I remember homonymous hemianopia is, you know, PCA starts with a P. So the P, I think about the glasses of this lady here. So that looks like two P's coming together. So it reminds me of glasses and the eyes, obviously, which points me towards homonymous hemianopia. It's just something that, you know, you may want to use to remember homonymous hemianopia for PCA stroke. The other one that's very specific to a PCA stroke is alexia without agraphia. Okay, so alexia without agraphia means that they cannot read or comprehend written language. So alexia means that the patient cannot comprehend or cannot read anything that's written down. Any written language cannot be processed. Without agraphia, so agraphia means that the patient cannot write, but it says without agraphia, so the patient can write sentences, can write a story. So alexia without agraphia means that the patient can write you a story, but they can't read the story back to you. They can write things, but they cannot read it out loud, or they can't read it, they can't understand what they've written down, but they can write. Okay, so that's alexia without agraphia. And the way that I remember alexia without agraphia is, you know, Alexa is like the Amazon product that helps you, you know, like your personal assistant. So Alexa, I know it's Alexa but it points me towards alexia. So Alexa helps me remember, because Alexa is your personal computer assistant, PCA. So again, the two specific findings for a posterior cerebral artery stroke is homonymous hemianopia and alexia without agraphia. Okay. And last but not the least, for ischemic stroke, we have the occlusion of the vertebrobasilar artery. So a vertebrobasilar artery stroke, very easy to remember because vertebrobasilar starts with a V, and I remember the 4 V's. So these are the most common presentations of a vertebrobasilar artery stroke. So we have vertigo, visual changes, vomiting, and vibrating eyes, or nystagmus. Okay, so vertigo, visual changes, vomiting, vibrating eyes, which is nystagmus. Okay, so now let's talk about the diagnosis of stroke. So when the patient first comes in and we suspect stroke, so the first few things that we need to do, the first thing I'd say is to do a finger stick glucose, and this is to rule out hypoglycemia, because hypoglycemia can actually present with focal neural deficits that can mimic some of the symptoms of stroke. So it's a bit ridiculous, right? Giving someone TPA or thrombolytics if they only have low blood sugar. Like, seriously, you would lose your license for that. So we need to do a finger stick glucose to start with, just to rule out hypoglycemia, to make sure that this isn't just an episode of low blood sugar. The next thing, like I put here, is to do a non-contrast CT head. So the thing with CT, this is like the first line. We don't usually go for MRI first, and I'll explain a bit. So non-contrast CT head. So why do we do this? This is actually not for diagnosis of ischemic stroke. What the head CT would tell us is, it would tell us if there's a bleed in the brain, if there's hemorrhage in the brain. So it kind of just guides us in terms of treatment. So obviously if we see hemorrhage in the brain, TPA is off the table. It's just used to guide our treatment. It's just to say whether this is a hemorrhagic stroke or not. But it's not really gonna be sensitive enough to show you the areas of like infarction. So this is where MRI comes into play. So MRI is far better at detecting areas of brain infarction, but the problem with MRI is it's very expensive, it takes a longer time, and it's not available in every institution. But again, it's more sensitive for detecting areas of brain infarction. And non-contrast CT head is just to guide you, to tell you if there's hemorrhage or not. It's not really going to help you diagnose if it's an MCA occlusion, anterior cerebral artery occlusion, you know, vertebrobasilar artery occlusion. It's not going to help you do that. Other things, so other additional tests that we can do is we can do an ECG, which is like my favorite, as you all know now. So why do we do an ECG? So we will do an ECG to rule out causes of potential causes of stroke. So for instance, it can tell us if someone has atrial fibrillation, which we all know is a massive risk factor for stroke. So if we treat their stroke symptom and we don't identify AFib as a cause, then they can probably have another episode of stroke, so we don't want to miss this. We do an ECG to rule out atrial fibrillation, which can be the source of an embolic stroke, okay? We can also do an echocardiogram, and this is to rule out other cardiogenic or other aortic sources of a cerebral occlusion, okay? So another thing that we can do is we can do neurovascular imaging, so like your CTAs, your MRA, and this is to rule out like large artery occlusion. And this is done to help us identify if this patient is like a candidate for mechanical thrombectomy. So obviously mechanical thrombectomy has less risks compared to TPA. It's actually one of the treatments that we use, but it's not for everyone. So there's a specific criteria for mechanical thrombectomy. The patient must have a significant occlusion, I think 50 to 99%. And it can be done within 24 hours. Okay, so I'll talk about treatments in the next slide, but this is your diagnostic workup for a stroke patient. Okay, so now let's move on to the treatment of an acute ischemic stroke. So there's basically two groups of treatment. So we can give TPA, your thrombolytics, your clot busters, or mechanical thrombectomy. So let's start with thrombolytics. So a thrombolytic, for instance, Alteplase, this is a clot buster, as I said. This can only be initiated within 4.5 hours of the onset of symptoms. The guidelines are very strict about this because after that 4.5 hours window, that frame, the risks would outweigh the benefits. So we need to make sure we give TPA within 4.5 hours from the onset of the stroke symptoms, the ischemic stroke symptoms. So actually in certain patients, the 4.5 hour window should be dropped to 3 hours. So for instance, if the patient is over 80 years of age, if they are on any sort of anticoagulant, if they have had like a combination of an ischemic stroke in the past and diabetes mellitus, or if they have a really severe stroke, typically we would want to give the TPA within less than 3 hours instead of that 4.5 hour window. So just to go over some of the contraindications of TPA, because TPA comes with a lot of risks. So this is how I remember it. So instead of saying TPA, I put extra letters. So TPAIN, which is T-pain, the wrapper. So I say T-pain is 45. So to remember the contraindications for TPA, I say T-pain is 45. He's probably not 45. Don't know how old he is, but this is just a mnemonic that I use. So T is for trauma to the head in the last 3 months. P is for platelet count of less than 100,000. If there is, so A is for active internal bleed anywhere in the body. I is for intracranial hemorrhage ever. N for neurosurgery in the last 3 months. I is for any intestinal malignancy or intestinal hemorrhage in the last 21 days. S is for stroke within the last 3 months. That's ischemic stroke actually. And 45 is to remind you for the 4.5 hours that you need to give TPA, okay? So these are some of the contraindications for TPA. I don't expect you to remember this, but this is just a good mnemonic that I use. So that's everything for thrombolytics. I think we can move on to mechanical thrombectomy. So mechanical thrombectomy is the other treatment. So if someone cannot get thrombolytics, if someone is not a candidate for Alteplase, for example, the symptoms of stroke started 8 hours ago. So that's outside of the 4.5 hour window. We can't give them thrombolytics. We can't give them Alteplase. So we need to go to the other kind of treatment that's available, which is mechanical thrombectomy. So mechanical thrombectomy, it can be done up to 24 hours. Basically what it is an interventional radiologist or a surgeon just, goes in there, cuts it open, takes out the clot, pulls out the clot, quite literally. And there's a lot less risk with mechanical thrombectomy compared to TPA, but again, mechanical thrombectomy is not for everyone. So the candidates for mechanical thrombectomy is a large artery occlusion in the anterior circulation. So I think that, you know, in terms of percentage, it should be between 50 and 99% occlusion, and we can find out, we can get this information from when we do like our MRA or our CTA. Okay, so another thing that I put on this slide is about the blood pressure. So if our patient is not getting TPA, we do not really touch their blood pressure until it reaches, or until it goes over 220 systolic or 120 diastolic. Okay, so I'll say that again. We do not touch. So if someone comes in, for instance, and we suspect stroke, we do all the diagnostic workup, blah blah blah. We do the assessment and we decide that this patient is not a candidate for thrombolytics, so therefore mechanical thrombectomy, and they have a blood pressure of, like, let's say 200 over 120, which is, you know, that's hypertensive. But in this case, we do not touch their blood pressure until that systolic blood pressure goes over 220, or that diastolic blood pressure goes over 120. And the reason for this, if you think about it, in an ischemic stroke, so that area distal to the occlusion will have a low blood pressure. So actually maintaining that high blood pressure maintains the perfusion in those areas of the brain distal to the occlusion that is not getting enough perfusion. Okay, so I'll say that again. If the patient is not getting TPA, we can let their blood pressure rise to about 220 over 120. We only intervene if systolic rises up, well, over 220 and diastolic rises above 120, because the perfusion distal to the occlusion will be very low. So that elevated blood pressure actually maintains the perfusion in those areas of the brain that's being hypoperfused due to the occlusion. Okay, so we only intervene when it's greater than 220 over 120. Or actually, if our patient is receiving TPA, we need only to intervene when the blood pressure, when systolic is over 185 and diastolic is over 110. So just remember those numbers. So these are your treatments for acute ischemic stroke. A little bit about blood pressure management there, and TPA contraindications as well. Okay, so just a part of treatment. So we need to talk about the adjunct, or like the long-term management for patients who've had stroke. So these are aimed in terms of like reducing the complications, reducing the recurrence of stroke or ischemic stroke. So the first one is antiplatelet therapy. So that's your aspirin, your clopidogrel. So a very important thing to remember here is if they didn't get TPA, then they must be on antiplatelet therapy. If they got TPA for the treatment, then we have to wait for at least 24 hours before giving them any sort of antiplatelet therapy like aspirin or clopidogrel. The next one would be statin therapy. This has been shown to reduce the incidence or recurrence of stroke, especially if the patient is high risk, if they have like hyperlipidemia and things like that. And the last one is lifestyle changes. So we need to encourage the patient to reduce the modifiable risk factors. So like ask them to stop smoking if they can, exercise more, reduce their weight, and have a much better control of their hypertension, diabetes, and other comorbid conditions that puts them at a higher risk of getting another stroke. Okay, so now that we've discussed everything about ischemic stroke, let's move on to hemorrhagic stroke, so the other type of stroke. So there's four main types of hemorrhagic stroke. So we have epidural hematoma, subdural hematoma, subarachnoid hemorrhage, and an intracranial hemorrhage. So we'll go over this one by one. Alright, so let's start with an epidural hematoma. So an epidural hematoma is a bleeding between the skull and the dura mater. Okay, so typically this is associated with a temporal skull fracture, particularly in children. So the most common artery to be involved in this bleed is the middle meningeal artery. Okay, the middle meningeal artery. So this is characterized by a loss of consciousness followed by a lucid interval. So a lucid interval means that the patient got better for a period of time after losing consciousness. And obviously the main diagnostic tool would be CT. It would show us the bleed. It would show us, for epidural hematoma particularly, a convex shape hematoma. So it's like this, convex shape hematoma. So just to summarize, epidural hematoma, I use this kind of mnemonic to help me remember everything I need to know about epidural hematoma. So if you notice, it starts with epi, EPI. If you rearrange those letters, it becomes pie. So epi, pie. So I say to myself, a Lululemon pie. A Lululemon pie. Pie for epi, so epidural hematoma. For middle meningeal artery, so this is the source of the bleed typically, middle meningeal artery. Lulu reminds me of lucid, so this reminds me that the patient loses consciousness and then it's followed by a lucid interval and the patient is, appears to be absolutely fine. And lemon is how I remember the shape of the bleed. So this looks like a lemon to me, the shape. So it's a convex shape bleed or convex shape hematoma. So this is how I remember everything I need to know for epidural hematoma. So again, epi, if you rearrange pi, so a Lululemon pie, for middle meningeal artery bleed, Lulu for lucid interval that follows an episode of like loss of consciousness. Lemon is for the shape of the hematoma, so lemon is like convex shape, so it reminds me that on a CT scan I would see a convex shape hematoma for an epidural hematoma. Okay, so moving on to subdural hematoma now. So subdural hematoma, so this is usually caused by the bleeding of the bridging veins located between the arachnoid membranes and the dura. So bleeding between the dura and the arachnoid membranes, yep, and it's caused by the tearing of the bridging veins between these structures. Okay, so this is most common in elderly patient and alcoholics. So specifically after trauma. So after an elderly patient has had a fall, for instance, they're at risk of subdural hematoma, especially if they've hit their head, or following like a motor vehicle accident. And the reason why a subdural hematoma is more common in elderly and alcoholics for that reason is because of cerebral atrophy. So aging in alcohol leads to cerebral atrophy, meaning that if we have atrophy, there would be like a larger space between the arachnoid membrane and the dura. So this larger space kind of stretches those bridging veins. So when these bridging veins are stretched, they're pulled across a greater distance and therefore they become weaker. Okay, so that's kind of the reason behind why a subdural hematoma is more common in the aging population and in alcoholics. It's because of that cerebral atrophy, increasing a distance between the arachnoid membrane and the dura, stretching those bridging veins, causing them to become weak and to tear more easily. So on CT, we would see a crescent-shaped hematoma for subdural hematoma. Remember, for epidural, it's a convex-shaped bleed. For subdural, it's a crescent-shaped bleed. Why is it crescent-shaped? Well, because it just the bleeding just follows the contour of like the overlying dura. So here, that's the crescent-shaped bleed. It just follows the contour of the overlying dura. So how do I remember subdural hematoma? So I say, instead of subdural, I say subdur, like door, like the door, subdural hematoma. Subdural, sounds really funny, but door is a mnemonic that I use for subdural hematoma. So subdural hematoma, D for drunk, and O for old. So these are the populations of people that's most commonly that we see subdural hematoma most commonly in. So again, alcoholics and the elderly, because of that cerebral atrophy, especially following like a traumatic fall or traumatic brain injury or motor vehicle accident, things like that. Okay, drunk and old, elderly and alcoholics. O for overpass. So overpass is also called a bridge. So this reminds me that this is because of the tearing of the bridging veins between the arachnoid membranes and the dura. Okay, overpass for bridge, tearing of the bridging veins between the arachnoid membrane and the dura. This doesn't really follow, but R is the second letter for crescent. Okay, this reminds me that this is a crescent shape bleed on CT. So it's a crescent-shaped hematoma because the bleeding just follows the contour of the overlying dura. So this is a crescent shape. We can see it here. So that's all for subdural hematoma. Okay, so the third one is subarachnoid hemorrhage. So a subarachnoid hemorrhage is the extravasation of blood into the subarachnoid space between the pia and the arachnoid membranes. So this is basically like bleeding within the meninges and into the ventricles, where the cerebrospinal fluid is, and the most common cause for this is a berry aneurysm. So the bleed, an imaging like CT or MRI, it would look more diffused. They won't be like on the lateral borders like we saw in epidural and subdural hematoma. In epidural, it's a crescent-shaped bleed on the lateral border of the brain, and a crescent-shaped bleed for subdural hematoma, again on the lateral border of the brain. For subarachnoid hemorrhage, the bleed is kind of more diffused, like I said. And in terms of symptoms, so the symptoms is not like an insidious onset. It's not gradual. It's very sudden. It's very acute. So a patient can literally be reading a book. They're feeling totally fine, and all of a sudden, bam, 10 out of 10 headache in terms of severity. So the patient can complain of a headache, saying this is the worst headache I've ever felt in my life. It's a 10 out of 10 headache. Or they can even say like a thunderclap headache. Okay, so thunderclap headache, worst headache of my life. This very like pathognomonic for subarachnoid hemorrhage if you see this in a clinical vignette. So don't forget that. The patient can also present with symptoms of meningeal irritation, so like nuchal rigidity, photophobia, lower back pain. And the reason for this is because, like I said, there's bleeding, there's blood coming to the meninges into the ventricles, and then there's going to be breakdown of those blood products into the cerebrospinal fluid, leading to like a septic meningitis, causing these sort of meningeal irritation symptoms. Okay, in terms of diagnosis, the first thing we're gonna order for all of these hemorrhagic bleeds, hemorrhagic bleeds, like synonymous hemorrhagic strokes, is a non-contrast CT head. For subarachnoid hemorrhage, it might be negative. So just bear that in mind. You're not going to see anything very, very specific. You might not see anything specific. So what you can do is do a lumbar puncture. So that's when you like extract some CSF fluid, and you would see something called xanthochromia. So xanthochromia is the yellow tinge CSF, and this is because of the breakdown of those blood products in the CSF, like I said. So red blood cells get broken down into a component called bilirubin, and that has like a yellow tinge to it, so it tinges the CSF in a specific color, like a yellowish color, and we can observe that when we do a lumbar puncture, and this is called xanthochromia. So just to summarize subarachnoid hemorrhage, basically it's a bleeding into the subarachnoid space between the pia and the arachnoid membranes, bleed into the meninges, then into the ventricles, and then blood products get broken down in the ventricles, and it can cause some sort of meningeal irritation symptoms like nuchal rigidity, photophobia, back pain, and the patient will complain of a headache that's a very like severe headache, 10 out of 10 headache, thunderclap headache, worst headache of my life, that literally came on very suddenly. Okay, and in terms of diagnosis, again, first line would be non-contrast head CT, it might not show us anything. It might be negative. If we get an MRI, maybe we'd see more diffuse bleeds, but not on the lateral borders. And the main diagnostic tool for subarachnoid hemorrhage is a lumbar puncture, and we would see xanthochromia, or that yellow tinge CSF, due to the breakdown of red blood cells in the ventricles into a substance called bilirubin. Okay, so last but not the least, we have intracerebral hemorrhage. So intracerebral hemorrhage, as the name suggests, intracerebral, it's within the cerebrum. So it's a bleeding into the brain parenchyma. So like this, it's within the brain parenchyma. And actually, intracerebral hemorrhage is the second most common cause of stroke. Ischemic strokes are the most common, and then the second most common would be an intracerebral or intracranial hemorrhage. Risk factors include older age and hypertension. There's really nothing much you need to remember for this. Just remember, it's a bleed within the brain parenchyma, and it's the second most common cause of stroke after ischemic stroke, and that's it. Okay, so let's do questions really quickly. So question 1. A 67-year-old male with a history of hypertension and hyperlipidemia arrives at the emergency department accompanied by his wife and daughter. His family members state he is unable to speak and lift his right arm. Okay, unable to speak and lift his right arm. When you ask the patient to puff out his cheek and smile, you note a prominent drooping on the right side of the face. Okay, so prominent drooping on the right side of the face. The patient likely has a stroke of which cerebral artery. So if we just pick out the very important information here from the clinical vignette, he says, okay, the family member says that he's unable to speak, so that's aphasia, and lift his right arm, so we have aphasia, right arm involvement, and drooping on the right side of the face. So aphasia, involvement of the right arm and the right side of the face. So this is a stroke in which cerebral artery. So this is actually an MCA, an MCA occlusion. So remember, MCA, my mnemonic was change MCA to MAD, which is MAD. MCA to MAD. MAD, because remember that cartoon when someone gets mad, they raise their arm and their face turns red. So we have arm involvement and face involvement, which is found here. And also they scream, they yell. So that screaming and yelling points me to aphasia. So that's how I remember it, okay? So because the symptoms are on the right side of the body, right side of the face and right arm, we can say that this is actually a left middle cerebral stroke, okay, because it affects the contralateral side. So the answer for this, the patient has a likely stroke on the left middle cerebral artery, okay? Okay, question 2. A 63-year-old male presents today to the emergency department complaining of a neck stiffness and a sudden onset severe headache unlike any other he had ever had before. His past medical history includes only hypertension. While speaking to him, you notice he is squinting his eyes and he asks if you can dim the lights. You order a CT of the head, which is negative. Which additional test should be performed for the suspected diagnosis? Okay, first of all, what diagnosis do we suspect in this patient? He complains of a sudden onset severe headache, unlike any other he has ever had before. So that is pathognomonic for a subarachnoid hemorrhage, okay? Also, we see some meningeal irritation symptoms. So he has neck stiffness, he has nuchal rigidity, and he is squinting his eyes and asks you if he can dim the lights. So he has photophobia and nuchal rigidity, which are symptoms of meningeal irritation. And this happens in subarachnoid hemorrhage because of the breakdown of blood products in the ventricles of the brain, leading to irritation of the meninges, okay? So leading to actually meningeal aseptic meningitis, which causes those meningeal symptoms. So what additional tests should be performed? So we've ordered a CT of the head, so that's the first line, and it's negative, which we can expect from a subarachnoid hemorrhage. What additional tests should be performed? So the diagnostic test in this scenario would be a lumbar puncture. So a lumbar puncture would show us xanthochromia, which is that yellow tinged cerebrospinal fluid. And this is because of the breakdown of red blood cells into bilirubin in the cerebrospinal fluid. Okay, so I hope that makes sense. Okay, question number 3. A 76-year-old male accompanied by his daughter has been diagnosed with an acute ischemic stroke. His blood pressure is 168/92, O2 saturation is 98%, pulse 88. He was known to be well 2 hours ago when his daughter spoke to him by phone. She states that he has a history of hypertension, diabetes mellitus, and celiac disease. She's very worried about him, stating that this is his second stroke in the last 3 months. Would this patient be an ideal candidate for TPA? If not, why? Okay, so remember that we only have 2 groups of treatment for stroke. So we have, for ischemic stroke, we have TPA and we have mechanical thrombectomy. So would this patient be a candidate for TPA therapy? So remember, for TPA contraindications, I say T-pain is 45. So actually, one of those contraindications is an ischemic stroke in the last 3 months. So here we have this patient. The doctor said that this is his second stroke in the last 3 months. So this actually excludes this patient. That meets one of the exclusion criteria for TPA contraindications. So this patient is not ideal for a TPA therapy. So probably this patient would have to go a mechanical thrombectomy. Question number 4. Which artery is the most common to be involved in an ischemic stroke? Ischemic stroke. So, we have the MCA, the ACA, the posterior cerebral artery, we have the vertebrobasilar artery. So which one is the most common in an ischemic stroke? And that's actually an MCA. MCA, medial cerebral artery, MCA, most common artery to be involved in an ischemic stroke. Actually, it's around about 7% of the cases of ischemic stroke. So the answer to this question is the MCA. Okay, so this is the last question, I believe, question 5. A patient being treated from ischemic stroke is greeted by a treating physician who informs him they are going to administer a medication called nicardipine into his IV to start lowering his blood pressure. He is unable to receive TPA due to a gastrointestinal malignancy. That's one of the other exclusion criteria, intestinal malignancy. The blood pressure in this patient is likely exceeded what systolic and what diastolic blood pressure. So remember, I told you, you don't touch the patient's blood pressure in an ischemic stroke unless the blood pressure goes over 220/120. Okay, unless they're having TPA, which means that you have to maintain it under 185/110. But in this case, he's not receiving TPA because of a GI malignancy, and they're giving nicardipine to this patient, which is a antihypertensive med. So it's a blood pressure lowering medication. So this means that the patient has likely exceeded that 220/120 blood pressure mark. That's why they're starting to intervene. Okay, so we only intervene if the blood pressure rises above 220/120, because in an ischemic stroke, the area distal to the occlusion is becoming hypoperfused, so maintaining a higher blood pressure is actually beneficial for these patients unless they go over 220/120.